Hello everyone. Today we would be talking about pleural effusion. Pleural effusion is defined as excess quantity of fluid in the pleural space. Normally, a very thin layer of fluid is present in this potential space. When pleural fluid formation exceeds pleural fluid absorption, then fluid enters the space from the capillaries of the parietal pleura, interstitial space of the lung via the visceral pleura, and from peritoneal cavity through small holes in the diaphragm. Pleural fluid is removed via the lymphatics situated in the parietal pleura. Four main types of fluids in the pleural space are hydrothorax, hemothorax, chylothorax and pyothorax or empyema. Causes of pleural effusion may be divided into exudative causes such as due to neoplasm, infections and immune disorders. Transudative pleural effusions occur due to the disbalanced Starling forces, such as increase in hydrostatic pressure or decrease in the oncotic pressure. These are exudative causes shown in detail, including malignancy, infections, immune disorders, abdominal diseases, pulmonary embolism and miscellaneous causes. Transudative causes include congestive heart failure, cirrhosis, peritoneal dialysis, myxedema and nephrotic syndrome. Large pleural effusions are caused by the three T's, namely, tuberculosis, tumor, and trauma. Small or slowly progressive pleural effusion is rarely symptomatic, while large effusion causes breathlessness with dull pain. Effusion due to malignancy tends to quickly fill the pleural space and causes recurrent dry cough. Pleuritic pain is seen initially when associated with inflammatory disease. Common symptoms of pleural effusion are shortness of breath, chest pain, cough, hiccups. Patient may have no symptoms at all. Breathlessness is the most common symptom and indicates large effusion. It occurs in almost half of the patients of malignant pleural effusion. Chest pain is pleuritic, hence is aggravated by cough, hiccups and deep inspiration. Intensity of chest pain decreases with increase in pleural fluid. Transudative effusions generally do not cause direct irritation of the pleura. Chest examination findings include decreased chest movements of affected side, dull note on percussion, absent breath sounds and decreased vocal resonance on auscultation. Pleural rub is seldom present, but when present, best heard over the area of pleural inflammation, over posterior inferior aspect of thoracic cage, or over inferior lateral anterior surface of thoracic cage. It is described as a rubbing or grating, harsh, dry, and scratchy sound that disappears with breath holding. Asymmetric expansion of thoracic cage, with lagging expansion on the affected side is known as Hoover sign. To differentiate between pleural rub and crepitations, we apply pressure on chest piece of stethoscope over the chest area. Increase in the adventitious sound is associated with pleural rub. Left-sided pleural effusion point towards esophageal rupture, splenic abscess, pericardial disease. Right-sided pleural effusion are associated with liver cirrhosis, peritoneal dialysis, Meigs's syndrome. Major complications of pleural fluid effusion are collapse, empyema and iatrogenic pneumothorax. Diagnosis of pleural effusion is done by chest radiograph, computed tomography, ultrasound of chest, pleural fluid aspiration and an analysis. Here chest radiography shows right costophrenic angle blunting, right lower and mid-zone homogeneous rising opacity suggestive of right-sided pleural effusion. Fluid of 100 to 300 ml leads to blunting of costophrenic angle. Interlobar pleural effusion mimics a tumor and causes diagnostic problems. Hydropneumothorax shows air fluid level and needs to be differentiated from large lung abscess and infected bulla. Pleural fluid present normally in lungs has a pH of 7.6 to 7.64. Protein level ranges from 1 to 2 gram per deciliter. Leukocytes fewer than 1000 per cubic millimeter, glucose content similar to that of plasma, lactate dehydrogenase level less than half of plasma, sodium, potassium and calcium concentration similar to that of the interstitial fluid. Light's criteria is used to differentiate pleural fluid into exudative and transudative effusion. If any of the given three criteria are fulfilled, then the pleural fluid is said to be exudative. If none of the three criteria are fulfilled, then a diagnosis of transudative effusion is made. In cases of minimal pleural effusions with known etiology, the underlying cause is treated. Therapeutic thoracocentesis is indicated only if the patient has breathlessness or recurrent accumulation of pleural fluid occurs. Tube thoracostomy or chest ICD insertion is done only in cases of hydropneumothorax, empyema, malignant pleural effusion and massive pleural effusion. Pleurodesis is done in select cases, such as palliative care in malignant pleural effusion. Thank you for your patient listening.